So I'm Sophie. I know quite a few people in this room, but for those that don't know me, I qualified as a nurse 10 years ago now, which is quite scary, and I qualified as a district nurse 5 years ago. And for my whole career, I've worked in community nursing. So from a professional and a personal point of view, I find weight management really interesting. Like people said, we don't have a pathway for people who are overweight or obese on the island. So that is what I looked into. So weight management pathways, but basically I explored community nurses' views on the implementation of a weight management pathway in the local health and social care service. So just a brief overview of the talk I'll be giving today. So I'll talk about the sort of rationale and the background of it, the actual weight management pathway that I developed, the research methodology I used, and then the findings and future recommendations for it. So a little game for you all, so you're not all sat there bored. Might be a long 20 minutes, it might not, who knows. So, true or false? Globally, 1 billion people worldwide are classed as overweight or obese. Shout it out, don't put your hand up. True or false? False, why false? Yes, so 1.9 billion adults are classed as overweight or obese, and of these 650 million are obese. Nationally, true or false, 28% of adults in the UK are obese.
False.
Why would it be false? Higher? It's actually true. 64.2% are overweight or obese. And then locally, true or false, 43.9%, Pip's ruined it a little bit for me. 43.9% are overweight or obese. It's false. It's 64.3%. So it's actually a little bit more than the UK, and 27.7% are classed as obese. The problem with these statistics is they're actually from 2019. There is a lack of recent statistics, probably due to COVID and gathering data. So they're actually quite old statistics. So the impact of obesity. So an increase in the risk of comorbidities. So we know that overweight and obesity can increase things like cancer, cardiovascular disease, type 2 diabetes. In 2020, 52% of all deaths in the UK were either caused by cancer or heart disease. And after smoking, being obese is the second biggest cause of cancer. So we know it has a huge impact on individuals' health and well-being. In 2019, there was a study, and in 2019-2020, there was a study. Basically, people who are obese have a 33% increased risk of dying if they get COVID. The cost to society. So Pippa briefly mentioned the sort of cost. So Public Health England estimate that it's about a 6 billion cost to the NHS every year. But to wider society, it's actually about 27 billion. So that's things like people being off work with their comorbidities caused by it, sick pay, all those things, so £27 billion. And there's an increase in service demand, so 1 million hospital admissions in 2020 were caused by obesity related issues, and that was 2019-2020. That was actually a 17% increase from the year before. And those who are obese are 3 times more likely to need social care, so things like home care, special equipment in the home, things like that. So obesity in Isle of Man, I'm not slagging anyone off, by the way, this is just factual information, so I feel like a bit bad, but we're going to go there. So 2009, the Isle of Man Health and Lifestyle Survey by Public Health found that 50.4% of adults were overweight and 15.9% were obese. We'll fast forward to what we've just talked about, and it's now that. So in 10 years, we've gone up by over a percentage every single year in the increasing levels of overweight and obesity. As we said, 3 years old, the statistics, let's be honest, who didn't put a few pounds on over lockdown? Okay, we weren't going to the gym, weren't allowed out to exercise, so those figures are probably higher now. Yet, despite the many strategies and policies that the then Department of Health and Social Care, now in Manx Care obviously, so the 2013 Plan for Tackling Childhood Weight and Obesity, the Isle of Man 5-year health strategy specifically discussed obesity management, and the Public Health Annual Report in 2018 was focused on overweight and obesity levels in the Isle of Man. So despite all these things, yes, we can say let's do something about it, yes, we know it's an issue, but what are we going to do? There has to be a plan for the plan. You can't just make these things, say these things, we're going to do them. You have to actually come up with a way to do something about it. So, locally there isn't a weight management pathway. If you are a nurse and you do an assessment in the hospital, in the community, you are going to weigh someone, and then if they're underweight, they score a score, and you say, oh, you're underweight, here's a leaflet on how to put weight on. Have some puddings, bit of double cream on your apple pie every night. But when they are overweight, they score 0, and we sort of say, you're overweight, you're obese, you need to lose weight. But people eat less, move more. Okay, that sounds easy, but it's not easy for everyone. So I'll tell you about the weight management pathway, but following all that, this was my research purpose. So following the review of relevant literature, I noticed that there was a gap in research, specifically because of my background in district nurses' views and beliefs regarding weight management, and also little research pertaining to their views of the implementation of one. I did this research because I believed it could bridge a gap and provide the local community nursing service along with Manx Care with the information regarding the need for one, and hopefully encourage and facilitate local change, and also empower staff. They're the ones that are going to be delivering this pathway, they're the ones that are going to be involved in its development and what we're doing with it. So they need an opinion. We need to empower our staff. And so that could then reduce potential barriers to change, because if we can find out what might stop them wanting to get involved in this, we can then reduce barriers to change. So this is, I'm not going to go through it, this is basically the pathway I developed. So I reviewed loads of pathways across trusts, across like national pathways in the UK, different trusts in the UK. I picked ones that were sort of based, I guess, on our population, the ruralness of it, and I picked 5 of them, and I picked bits out of those and tailored it to our local population. I also wrote a supporting document to go with it on how we would actually, on each section, so it's based on NICE guidance, the NHS weight management tiers as well. So all of this is in the document as well, and I'm sure that if anyone wanted it, I'm more than happy to send it to you. Might not decide if you don't. So that's what I developed, and that was based on my literature review and all the things that I'd looked at. And then when I was looking at my methodology, I looked at the approach that similar literature had done. So I picked an interpretive phenomenological methodology, and that was in keeping with the qualitative research that I'd chosen to do. And this type of research allowed my experience as a nurse in that sector to basically influence my research, but also allow me to really collect that sort of in-depth, rich data as well. The sample was purposive homogeneous sampling. So basically that means that my research was looking at community nursing. This type of sampling allowed me to pick community nurses without it being seen as sort of basically being objective still, and making sure that my data was still valid and reliable. So 6 people responded to the call for focus groups, and that was out of 45 staff. That seems like a small number, however, the literature on focus groups, 6 people is about the right number, and also it was a representative sample. There were a lot more studies with fewer actual staff members from a sort of bigger sample population, but it also was representative because I had a Band 7 team leader, 2 Band 6 district nurses, and 3 Band 5 registered nurses, which sort of reflects the hierarchical structure of the teams within community nursing anyway. So my data collection was focus groups. So I carried out the focus groups. There were 6 focus group questions, which I came up with based on my research and also the data analysis tool I chose to use, which I'll talk a bit more about in a minute. The focus groups were audio recorded, and I used, as a novice researcher, aid memoirs and a researcher checklist to make sure that I'd sort of thought about everything going into these focus groups. And then for data analysis, I chose inductive thematic analysis. That goes along well with that phenomenological data because it helps to generate themes. I transcribed the focus group audio recording verbatim, and then I sent it back to the people that were in the focus groups for them to validate the data. And then I used the theoretical domains framework to aid in the analysis. These are like really big, long words which sound like really confusing, but basically the theoretical domains framework was in one of the articles I reviewed from my literature review, and it basically helps us to look at why healthcare professionals and patients might be reluctant to change. It's a validated behavioural tool as well, and the particular one I looked at had 12 domains, but the guiding document I used in order to use this properly basically said pick the domains that make the most sense in respect of your research. You don't have to pick all of them. So I picked knowledge, skills, social or professional role and identity, beliefs about capabilities, beliefs about consequences, environment and resources, and social influences. And then I used the domains as my codes for the research, and I then, after I coded all the data analysis, and I put it into themes based in the domains. So there were 10 overall themes within the 7 domains. So the first one was knowledge. So the theme in this one was health promotion advice. Participants basically discussed that the advice that they currently provide to patients, and that included anything from smoking cessation, their weight, diabetes management, mental well-being, wound management, and exercise. I also got to say, what I did when I wrote my report up for my research was I used participants' quotes to back up what I was saying and to back up the actual findings. So these are all quotes from the participants in the focus groups. So for skills, the themes were staff training and motivational interviewing. So staff were aware that if there was going to be a weight management pathway introduced, they would need training on it to basically effectively use it and give the right advice. A quick interesting point, because I know I'm running out of time, but it was really interesting. So when you do the DM qualification here, you become a V100 nurse prescriber. So one of the district nurses said, well, why can't we as V100 prescribers go, cut out the GP middleman and we prescribe the exercise and weight loss programs instead? So I thought, this is really interesting actually, why can't we do that? So I researched it, and Sweden are really hot on that. So most of their district nurses can actually prescribe exercise and weight management programs. So that can be something that we look at here. And also motivational interviewing, which is a nice recommended behaviour change technique. So looking at why someone wants to change or why they don't want to change, and how we can actually help them to do that. And then environment and resources basically found that there was a lack of current local weight management pathway, that we use a must assessment tool which isn't really fit for the purpose of helping someone lose weight. It's more about getting them to put weight on. And also the required resources. So at the time, and probably still currently, we have nursing crisis going on, the vacancies within the service. Would this be hard to implement something new with a lack of staff to bring it in? Also, Douglas, we've got the MSc and we've got all these amazing transport links, but actually out in Kirkmichael, are people going to struggle to get to classes, to the gym? How are they actually going to, and the transport links? So we need to do a joint strategic needs assessment across the island to see how we're going to actually get the resources in the right places for the right people. Social or professional role and identity, and this looked at the sensitive topic of weight management. So people basically said, but if I'm overweight, how can I go and tell someone else that they're overweight and how to lose weight when I'm not doing it myself? We find it as nurses quite a sensitive topic. We're happy to say eat some cream, but we're not happy to say stop eating the cream. So why is that? But if we have a pathway that supports staff in how to approach it, then people aren't going to sort of have a fear, because it's part of the assessment. We have to carry it out, and patients are going to be more understanding about that. And then staff engagement. So making sure we're empowering our staff and involving them in that change. Beliefs about capabilities. There weren't any overarching themes in this, but basically participants displayed an awareness of their confidence and competence in how they carry out weight management interventions already. Beliefs about this is the last one of the findings, I promise. We did start late, so it's fine, right? So, beliefs about consequences. So, patient engagement. So, making sure our patients are engaged. If you've ever, some people in here I know worked in community nursing before, so we might be the old person that little old lady sees all week, all day. We go tell them to lose weight, which might help heal their leg ulcers. Are they going to want to do that? Because actually, they're going to lose us in the process. And we know that some patients aren't compliant as well in the advice we give. Communication that focused on basically the lack of integration of our records, of our electronic record systems on the island, which would be something that would need to be looked at. And then social influences. Again, there was no overarching theme in this, but it highlighted basically that there might be a cultural or social norm within the service where we aren't discussing people's weight with them. So we're more likely to refer them if they're underweight, not necessarily ignore, but don't address it as much if they're overweight. And that was a running theme across all of the participants. Limitations. I was a novice researcher. I had never researched before. So I had to rely on a lot of research and checklists and aid memoirs to make sure that the data I was going to be collecting was reliable and valid. COVID-19 was an issue. Couldn't have too many people in the room, had to wear masks. Barriers to the implementation. So the whole point of this was to identify possible barriers so that if we do implement something, we can get rid of those barriers before we do it. So staff and service engagement. can we get our staff empowered and engaged to do this? It's going to be, all they're going to think is, oh gosh, another bit of paperwork to fill out, another assessment on EMIS to fill out. We want to actually make sure they're engaged, they know why we're doing this, they've got the training, they feel confident to do it. And then the cost. But short-term cost, training, working groups, development of it, long-term savings. We are going to potentially save lives and reduce the cost to our Manx Care service. Further research is needed, maybe with other healthcare professionals, other services. There would need to be a joint strategic needs assessment, which I've mentioned. A working group of multi-professionals to discuss how each service could work together. Staff engagement. And then eventually, hopefully and potentially, the introduction into practice. So how does this fit in with our island plan? So the Secure Island of Health and Wellbeing says we need an accessible, accountable and compassionate right care, right time, right place system. So this is basically what I'm trying to do, making sure we've got the right resources, making sure that they're in the right place. And it's going to be there throughout their lives. This is a pathway that can be done from, 18 all the way to 88. Collaboration with community partners in delivering services that help and assist people to keep safe and well. So it's going to encourage collaboration between services, that integrated care that we're working so hard, the wellbeing partnerships across the island. That is a big thing, and this pathway can bring people together to actually do that to help people.
3 minutes.
That's fine, no questions then. Yeah, I'm joking. Policies and services which mean that people can make healthy choices in communities that are safe and with infrastructure that basically promotes and supports their health and well-being. So we want people to make healthy choices. We want to give them that education and knowledge that it's not a quick fix. We can make it a sustainable lifestyle change for that individual, for that community, and support them throughout their life. So in conclusion, we've seen the clear evidence globally, nationally, locally. This is a massive public health issue. The findings from this study reflect the need for the local weight management pathway and also highlight potential barriers to its implementation. These barriers could then be looked at prior to developing it and help to reduce them and make it be as effective as it possibly can, which can then not only aid staff to carry out effective weight management interventions, but more importantly to create a healthier and more sustainable lifestyle for our Manx community. Done.
I'm so sorry, but I'm going to open it up to questions. So anybody? Fantastic at the back.
Hi, thank you, Sophie. I really enjoyed that. Can I just ask you, your focus group you said was the nursing staff. Did you consider including practice nurses and dietitians and a service user?
No, so that's what when I was saying about the future recommendations, I'm having the working groups. So that would include people like practice nurses, service users, and dietitians. So in the document that I've got, it basically does list all the people that could be involved. It's just that that is like a massive scale, and you would need a lot of you'd probably need support from Manx Care to be able to carry something like that out. But yeah, they were all considered because hopefully this would be something that could be implemented across Manx Care, but maybe as a pilot could be using community nursing because it's quite a sort of nice small service to introduce it into, but then with the potential to be used across the service.
Well, what I was thinking is if you got the practice nurses, the non-house man, before the obesity got escalated further, you could tap into that resource rather than wait till the obesity is at a
Yeah, so on the, obviously it wasn't up for very long, but on the weight management pathway, it actually says when you weigh someone, if their BMI is over 25, it sort of kickstarts this intervention and motivation. But if it's under 25, it actually still discusses, mentioning about what healthy lifestyle includes, about nutrition, exercise, how important that is. So that would still be given even if someone was at the correct weight. So yeah, it does include all of that as well.
Thank you.
Okay.
Yes.
Yeah, I thought it was very interesting, thank you. And I'm speaking from the perspective of somebody living in England. And as we were talking last night, I've been involved in obesity research for the last 10 years. One of the things from looking at it from the perspective of England is local authorities are getting out of obesity strategies. Yeah? So this isn't a counsel of despair, what I'm saying. This is exactly right, but the problem is they're getting out of anti-obesity strategies of looking towards personal responsibility, in inverted commas, as a way to address it. But I think we need to have more conversations about ways, and the thing you were mentioning there in your analysis, I think is absolutely right. But my sense is that behavioural interventions have only got mixed levels of success. That's one of the problems with it. One of the things you didn't mention here, I know again it's not very popular often in public health circles, is bariatric surgery. I've done some research on bariatric surgery which shows that's got the highest evidence for success over over 5 years. I just wondered if you'd considered looking at bariatric surgery as part of your
So we don't actually have anyone that does bariatric surgery here. So at the very bottom left, that corner over there, when the pathway was up, I looked into bariatric surgery, and basically we would have to almost sort of tender a service out to the UK because we don't have that specialist over here to do it. So I did look into that, and the sort of levels at, I think it's a BMI over 50, but a BMI over 40 with comorbidities triggers that bariatric surgery intervention. But I would hope that, sort of based on what you were saying back there about getting people involved before it gets to that point, that this weight management pathway would almost sort of kick in those brief interventions and not have to go that sort of really like hard-hitting bariatric surgery level. But yeah, it was, I did look at that, but there's nothing over here for that. Yeah.
No, thank you. I found that very informative. I see that what we're doing here is dealing with the issue as it arises. I'm just wondering, maybe with the success of this program, maybe, do you think you might look into preventative methods as well?
Yeah, so this would hopefully, like I say, there is like a whole supporting document. This is just like, it was like a 15,000 word dissertation, so this is really hard to get like a 20-minute snapshot of it all, but there is a whole pathway document that discusses about brief interventions, which are basically those where you sort of chip away at people and sort of give them that little really basic advice of preventative things. So I think public health is really pushing that, and the healthy eating and exercise. But my thoughts from a professional point of view of working in the community is that, especially with older people, looking at that holistic picture of, okay, we're preventative, but what if someone can't get out of the house? What if they are in fuel poverty? They don't have a cooker, they don't have a microwave, or they don't have that education awareness of what healthy eating is, that nutrition is. So this wouldn't just focus on lose weight, it would look at that bigger picture of how we can help someone live a sustainable, healthy lifestyle.
Wonderful, okay.
Mine's a really quick question, just for my own interest, really, okay. So I'm from Liverpool, I work for the University of Chester, and I was quite surprised to see that your statistics on obesity are on a par with Liverpool, a city of really high deprivation, and we've always had quite high obesity statistics. I'm just interested to know, just from your own point of view, I know it's only anecdotal, you haven't collected that information.
Yeah.
What has changed in the last 10 years, do you think, to make those statistics on such a small island really increase those levels of like 66%?
I think although we don't seem to have deprivation, and probably definitely not to the level that Liverpool does, but we do have, you know, people that live in sort of poverty over here, although it's not very widely known or thought about. And also, probably for the same reason as everyone else, fast food, you know, that sort of quick fix living of, you know, popping into the drive-through and getting something. This thought that maybe healthy living and healthy eating is more expensive.
Can I butt in? I did a piece of work on food security, and we talk about food security generally from the angle of have we got enough to eat? Food security now is far more about are we eating the right thing? And I did a piece of research with somebody who was starting a family in 1972 and somebody who was starting a family today, and their diet has changed completely. And the 22-year-old today talked about eating from scratch. She was vegan, she was healthy. Eating from scratch was lentils in a sauce that came to her that was full of things that our bodies can't actually process. Cooking from scratch in 1972 was going to the greengrocers and going to the butchers and getting food and cooking it properly. And that properly is unfair. But we have changed our lifestyles so significantly. So in 1972, this young mother walked with her pushchair down the hill to the butchers. In 2022, the young mother drives to Tesco, buys sugar, not real sugar, fake sugar-laden food. And she's addicted to it. And so what's happening in the UK is a real shame, because we should be getting rid of all those things at the counter. But we're not. And it's a bigger problem now than nicotine. And governments need to step in.
Yeah, well, I was going to say, I also think as well that it is that, you know, when I said a personal perspective, so I was 19.5 stone at one point. I lost 7 stone. I got a little bit on after having a kid. For a witch. But I lost a lot of weight. So from a personal perspective for me, it was that going to the doctors and you dreaded going and they'd just weigh you and go, you're obese, you need to lose weight. And then you'd step out the door and be like, I know that. I see that in the mirror every day. You don't have to tell me that. But there was no support for that. And I think for some people that can sort of cause like disordered eating, and then they spiral and go home and eat more.
Yeah.
So
and
I
this
think
is what
that
the 22-year-old today was doing. And she talked about a relationship with food. The 22-year-old in 1972 did not talk about relationship with food. And when I asked her the question, she said, what? So there's a real different relationship that we have with food now. And she would go to Tesco's at 10 o'clock at night and buy just stuff to make her feel better. And she knew what she was doing was wrong, but she couldn't stop herself doing it. And so there is a balance here between what the governments need to do to intervene and what do we take as personal responsibility. And the blame isn't necessarily fully on me. There is also bigger things at play. And there's a lot of interesting stuff about when they talked about fat being a problem. Actually, that was a decision that was made by lobby groups, and really it was sugar that was the problem. Anyway, I've got to say thank you. That's absolutely amazing. Thank you very much.